Today, I thought we'd talk about the iStent Inject, which is the second and now third generation of the iStent. Um, so I'm going to go ahead and start the video, and we'll talk as the video is rolling. Let's see. Okay, so basically we've already done the cataract surgery part in this case, and we're looking at the angle and direct gonioscopic visualization. The iStent Inject is is one of the minimally invasive glaucoma surgeries. And basically we're placing two small stents through the trabecular meshwork, creating improved flow from the anterior chamber angle from the anterior chamber directly into Schlemm's canal. So we're bypassing the inner wall of Schlemm's canal, the trabecular meshwork, the site of resistance to outflow of fluid for patients who have glaucoma. And so by placing two stents instead of one, we're hoping to recruit more collector channels in the angle. So that's one iStent Inject placed. These are about 0.3 millimeters or 300 microns in size, quite small. And I've placed one, and now I'm going to place one, preferably in a different quadrant in the angle. Whenever you place these, sometimes you'll see reflux of blood, and that's actually a good sign. It means you're probably close to a collector channel, and so you will hopefully theoretically get better outflow of fluid with this. And so here we see that we are getting some reflux of blood through the iStent Inject. I think shortly here we'll be zooming in and seeing that in a little more detail. So in my practice, I do these procedures in patients who are undergoing cataract surgery, where the main indication for surgery is to remove the cataract to improve the patient's vision. And I do these in patients who undergoing cataract surgery who also have a diagnosis of mild to moderate glaucoma, patients where their glaucoma is already well controlled. And our goal here is hopefully to improve control of intraocular pressure and decrease patients' adherence to medications. I looked at my own data, and with the first generation iStent, we're able to reduce medication use in about 45% of patients, with an additional lowering of intraocular pressure as well. So I'm just injecting some viscoelastic there, moving the heme out of the way, and once again just showing a magnified view of the iStent Inject as it sits there in the anterior chamber angle. So that's one case. Let's see if we can find another case here. All right. Okay, so this is a case of the iStent Inject W or the iStent Inject Wide, the next iteration of the iStent Inject. All right, so similar procedure. We go in, it's done after cataract surgery. We've gone in through the main wound here, and I like to put the one to the left side of the surgeon first. You can see it's actually very similar to the regular iStent in terms of placement. One thing you'll notice is it's a larger device. It's more difficult to over-implant these. And also, whenever you withdraw the trocar, which you use to place these, it's more likely that the iStent Inject W is going to stay in place and not come out with the trocar. So we've already placed one. We've placed the second one. I found these pretty similar procedure as a regular iStent. I think it is a little bit easier to do. I'm happy with the position of both these iStent injects in this patient's angle. So that's another case of the iStent inject. Okay, so I'm going to load up another video here. Okay. So this is a patient once again who's undergone, let's see, let me just make sure you guys can see this first. All right, so this patient once again has undergone cataract surgery. You can see the marks there, which I placed for placement of a toric lens, or either doing an LRI to orient myself in patients who are undergoing astigmatism correction. And we're coming through the main wound here with the iStent inject inserter. And once again, this is an unedited video, so please bear with me. So we can see there in the inserter, you can see the two iStents sitting there. And this is a problem that could sometimes occur with these, and hopefully the iStent Inject W fixes. So we see there's one iStent inject that I deployed there. We've got an annoying bubble. It's kind of in the way. But as I come out with the trocar, you can see that actually what I ended up doing is I ended up clicking the button again. So we can see, if you look at the trocar carefully, you'll see there's no more iStent injects there. So they've basically, both iStent injects have been placed on top of each other, or stacked on top of each other. So what do we do here? I guess theoretically we could just leave it where it's at. One is going to be deep, and then one is going to be right on top of it. But since that one's pretty superficial, I go ahead and remove the top one that's there. I go to another part of the angle, and I depress the inserter, and we're going to place this here in another part of the angle. So I remove the trocar there, and I'm happy with that position. I'm happy with how that looks. But now we have another iStent inject, which is in the first location where we injected. And so we're going to take a look at that one and see what we can do to salvage that one. We could obviously leave it where it is. It's not going to do any harm if we leave it deeply implanted. But what we do here is we try and address and get a little bit of exposure to that second iStent inject that's been over-implanted. Here you can see that the IOL is in position. We have viscoelastic on the corneal surface. That's why there's an irregular reflex, and this must be a premium IOL case. As I can tell, there's a bunch of cortical material floating around in there, and I've used the Shepherd's curettes to polish the underside of the anterior capsule. So we've got some nice heme reflux here at actually both implantation sites. And so we know we're in good location as far as being close to collector channels. And this is viscoelastic. We're going to go in and clear out the heme, so we can see the area that we're working in. So from this view here, I really don't see very much there. And so really, you can't tell that there's really anything there going on in the angle. But we've only got one iStent inject visible, so the other one must be somewhere. So once again, this is an unedited video, so we're seeing the entire case in real time as it as it happened. And here it looks like I'm going in with an MVR blade. And I'm going to use an MVR blade to basically perform a small goniotomy over the location of the iStent inject. And we're going to see if we can expose it. Okay, there it is. So basically we're just going, we made a small incision over the trabecular meshwork, and then I pushed down on that bottom lip to see if I could get the iStent inject to be a little bit more visible there and have access to fluid flow from the anterior chamber. So now we can see both iStent injects are visible. I'm going to go into some more viscoelastic here, and we're going to see if we can clear up our view and verify. But I'm happy already. I'm happy with what I'm seeing here. I'm seeing both iStent injects. Both of them are in the angle at the level of the trabecular meshwork. We've got 2 quadrants activated as far as improvement of outflow. And we are done with that part of the procedure. We're going to continue the case. We're basically going to do irrigation aspiration, finish up the cataract case, seal the incisions, and we'll be done. So this week we basically went a little bit over the iStent inject. Indications for surgery are, I'm doing this in patients who are undergoing cataract surgery, who have glaucoma that's already fairly well controlled. We're trying to hopefully decrease their need for medication use and get a little bit better intraocular pressure control. I'm not really doing iStent injects in patients who have uncontrolled intraocular pressure. I use other procedures for that, such as a Hydrus device or a KDB goniotomy or some other glaucoma procedure. But in patients who are undergoing cataract surgery, who are on glaucoma drops, my procedure of choice in conjunction with cataract surgery is to do an iStent or an iStent inject in these patients. Certainly there are lots of options out there, and each surgeon should do what they're most comfortable with. And as we get more data from these procedures, we'll be able to come up with more consensus as far as which procedures to do in which patients. So we showed 3 videos. We showed the iStent inject, which is the 2nd generation of the iStent, and we showed the iStent inject W, which is the 3rd generation of the iStent. And we showed how to correct one problem that can happen, which is when you inject both iStents on top of each other, or stacking the iStents. Sometimes I'll hear surgeons say, there was only one iStent that came in the inserter. Well, that's not the case. It's actually, you had 2 iStents in there, but you stacked them on top of each other. And what you have to do is you have to go pull one out and put it back, put it in the other quadrant, and then hopefully try and expose the other one. Or theoretically, if they're both in good position and secure, you can just leave it as is. That's it for tonight. If you have questions or comments, please reach out, make a comment down below, or reach out to me directly. And if you would do it differently, or you would do it better, let me know. All right. Have a good night.